Okay, so we've talked a little bit about how memory works in normal brains, but in this video I'm going to talk about a case where that fails, and that is in the case of Alzheimer's disease. So Alzheimer's disease is the most common cause of dementia, and dementia is just a way of saying a failure of memory. And affects millions of people, and age is a major risk factor for Alzheimer's disease. So as the population continues to age, it's only going to become a more common healthcare concern. So you're definitely going to see patients with this disease in the clinic. So let's talk about when that patient comes in, what are they going to look like? So let me just I'm going to do a timeline here. So it's a progressive disease, so that means it's going to change over time. So if a patient comes in early in the disease, one of the first things that's going to change is they're going to have trouble learning new things. So they might be able to tell you everything in detail about their kindergarten teacher from 80 years ago, but they may not be able to tell you what they had for breakfast or what they did yesterday, and they might have trouble learning new skills. So that's the first thing you're going to see. Not everyone's going to come into the clinic at this point. Now, as patients continue in the disease, they're going to develop sort of a concert of symptoms that I'm going to lump under disorientation. So their memory deficits are going to get worse, and so they may no longer be oriented to time and place. So you ask them where they are, they might not say they're in the hospital. They might say I'm at home, or hopefully in Aruba, someplace nice. And they may also be confused about what time it is. So they may not know who the current president is. And also in this stage, they may stop recognizing people who are familiar to them. So that can be quite difficult for caretakers as well, because they may be trying to, feed their loved one with Alzheimer's disease, and that person no longer knows who they are, and for all they know, they might have eaten 5 minutes ago, so they don't understand the motivation of the caretaker. And so this can kind of make them suspicious of the people around them, certainly understandably. So this can kind of be difficult as the disease progresses. And then finally, they're going to have some sort of gross systemic symptoms, like difficulty speaking, and swallowing, and sort of other difficulties with sort of everyday bodily function. So at this point, they're going to need full nursing care, and eventually this will lead to death, either from these deficits here or from another comorbid disease. But this is sort of what the person might look like over time who has Alzheimer's disease. So again, that's what the patient looks like on the outside, but what's going on in the brain to cause these, really huge changes? So let's now talk about the pathology. So what's going on in the disease state here? Okay. So again, we have kind of a timeline. So I'll draw the line down here. And the first thing that's going to happen in these patients is you're going to get amyloid beta plaques. So there's this protein called amyloid beta, and it's not going to be able to be cleared effectively. So that means over time it's going to build up, and there's going to be more and more of this amyloid beta protein, and they're going to form aggregates outside the cell that we're going to call plaques, but they're just sort of globs of this protein all stuck together because it can't be cleared properly. And now this is happening, maybe a decade before people even have symptoms. So this is sort of far in advance of when you're going to start seeing, these things on the timeline here. And what's interesting about this is we can actually image people and detect amyloid beta plaques in the brain. So we could actually find out with a lot of people if they're going to get Alzheimer's disease, 5 or 10 years down the road. Now, that doesn't make sense to do now because we don't have great treatments. So there's nothing we can do interventionally if we have that knowledge. But hopefully we have treatments in the future that do work, and this might be a way to detect patients before they have symptoms so we can intervene early. But for now, this is just the earliest starting pathology of Alzheimer's disease, and also the definition of Alzheimer's disease. So really the way to diagnose this disease is post-mortem. If you slice the brains of these patients, you'll be able to find these amyloid beta plaques. And if that's the case, then it was Alzheimer's disease, and if not, then it was another form of dementia. So this is sort of central to the definition of Alzheimer's disease. So next along this timeline, you're going to get neurofibrillary tangles. Fibrillary tangles. Okay, and this is going to be aggregation of a protein called tau. So both of these are just protein aggregation problems. They're just two different proteins, and the amyloid beta is extracellular, and these neurofibrillary tangles are actually within the neurons. So they're very similar, but those are sort of the subtle differences between the two. Okay, and then finally, these underlying pathologies up here are going to lead to neuronal death. So you're actually going to get loss of neurons in the brain. And so really, it's at the time that you have neuronal death when this timeline here is starting. So, so these are the underlying pathologies here, but it looks like this might be what's causing the start of these behavioral changes in Alzheimer's disease patients. Okay, so that's what's going on. I thought it might be cool to talk about some of the treatments, and unfortunately, it's not something that we're super good at now, but hopefully in the future, more treatment options will be available. But I'll talk to you about what we can do for the disease now. So let me just add that column up here, treatments. So right now there's really only one approved treatment, and that is an I'll write it out this time, acetylcholinesterase inhibitor. Okay, and hopefully you remember this a little bit from the neurotransmission lectures, but I'll just talk briefly. I'll give a brief review of why this might be helping in Alzheimer's disease. Okay, so let's look at our synapse again. And this is going to be a cholinergic synapse. So this presynaptic cell has choline in its synaptic vesicles here, and then the postsynaptic cell has choline receptors, so it can respond to the presynaptic cell. Okay, so one thing about acetylcholine, which is kind of interesting, is that unlike glutamate or GABA, it's not directly excitatory or inhibitory on this postsynaptic cell. So it actually modulates its ability to respond to other cells, and specifically makes it more active. So this is something that's really potent. So when this is released in the synaptic cleft, we don't want it, continuing to cause this neuron to be more reactive, because we want to maintain a balance in the brain of activity and inhibition. So what happens is that when it's released, there's actually acetylcholinesterase in the synaptic cleft, and this breaks down the acetylcholine right here where it's released. So it acts for just a really short time. And so normally that's good. It again helps protect the brain from being overexcitable and overactive. But you can imagine in a case like Alzheimer's disease where you have neuronal loss, one way you might compensate for that is by trying to make the neurons that are still there more active and more receptive to other inputs. So these acetylcholinesterase inhibitors get rid of this guy here. So the acetylcholine can act on the receptors longer and make these neurons more reactive to other signals. So that's really the only treatment that we have right now. Now that is addressing neuronal death all the way down here. And the current idea behind therapies that are being developed now, we might want to target these earlier pathologies before neuronal death.